May I now invite the chairpersons, Dr. Ushani Variapperuma and Dr. Shamita Dasanayakar, to commence the next session on Haemophagocytic Lymphohistiocytosis.
Okay, up next, we have an MDT. For that, I will introduce and invite the three resource persons on stage. Dr. Damayanthi Idampitiya, she is a consultant physician at National Institute of Infectious Disease, Angoda, with a special interest and training in infectious diseases. And then we have Dr. Manu Wimalachandra. He's a consultant clinical hematologist and a senior lecturer at Faculty of Medicine, University of Colombo. Our third speaker is Dr. Buddhika Somawardana. He is a consultant hemato-oncologist at National Cancer Institute, Maharagama. May I cordially invite all three resource persons on stage.
Good afternoon, everyone. Today we are going to discuss about an uncommon yet important topic, Dengue-associated HLH, a diagnostic challenge. To bring this topic to life, I will present a case history that highlights the complexities involved in diagnosing and managing this severe condition. My patient is a 44-year-old female, mother of 18-month-old child. She's a diabetic. She developed acute onset of fever accompanied by headache, nausea, vomiting and myalgia. Her NS1 antigen was positive, full blood count was normal, so she was diagnosed as having dengue fever and managed as an outpatient with daily full blood counts. On the 5th day of the illness, her platelet count found to be low and she was admitted to a private hospital and managed there for 3 days. And on the 8th day of the illness, she was discharged following improvement of her WBC and the platelet count. So the diagnosis was given as uncomplicated dengue fever. But anyhow, she was prescribed cefuroxime 500 mg BD on discharge as she continued to have high fever. She stayed at home for 5 days, but fever persisted with vomiting, malaise and loss of appetite. On the 14th day of the illness, she got admitted to our hospital. The reason for admission was persistent fever after recovering from dengue illness. Complaints on admission: fever for 14 days, vomiting, loss of appetite, altered level of consciousness. On examination, she was febrile, ill-looking, and she was tachycardic with blood pressure of 90/70. Her liver and spleen were palpable. Investigations: initial full blood count was normal, CRP was 15, ESR was 31. She was started on IV fluids because the blood pressure was towards low side and she was quite ill. And blood cultures were taken and started on antibiotics as the patient was very ill. Ultrasound scan abdomen confirmed mild to moderate hepatomegaly with mild splenomegaly. Blood picture was normal apart from occasional reactive lymphocytes. Dengue IgM was positive. Blood cultures were negative and there was no evidence of endocarditis on echocardiogram. The initial basic investigations were normal. However, if you look at the fever chart, you can clearly see persistent high fever spikes throughout the course of the illness. Her initial AST-ALT levels elevated and continued to rise progressively. Because high liver enzymes and the continuous high fever, further investigations were arranged. So, after the further investigations, LDH level was found to be 1638 and serum ferritin level was 15,839. Triglycerides were high and serum fibrinogen level was 550. Because of that, bone marrow aspiration and trephine biopsy was arranged and repeated the serum ferritin. On the following day, it was 46,410. This slide shows the bone marrow aspirate of this patient. The large cell indicated by the arrow is a macrophage that has phagocytosed several blood cells. Notably, in this bone marrow sample, nearly all the macrophages exhibited Haemophagocytic activity. So at this stage, I would like to invite Dr. Manu Wimalachandra to discuss about HLH and how to diagnose it.
Thank you. Chairperson, Madam and Sir. Good afternoon, ladies and gentlemen. And I'd like to thank the college and the presidents for giving me this opportunity to talk to you on this topic. So I will deal with a little bit of theory and later we go on to the discussion of the case. So my talk will be in 3 parts. One will be on the pathogenesis of HLH, number 2, diagnosis, and I'll come back later to give an overview of the management. So this is the 3 parts. Why does it happen? How can we diagnose? And how can we treat? Haemophagocytic lymphohistiocytosis. To describe it in one sentence, it's a syndrome of self-accelerated hyperinflammation induced by cytotoxic T cells and macrophages. And those two are the main actors of this whole scenario. It is a big word, and incidentally, it has the same amount of syllables as this big word called supercalifragilisticexpialidocious. And if you like to watch Disney movies like I do, you'll recall this word from Mary Poppins, where she uses this word to express a sense of euphoria, a profound happiness after her horse wins a horse race. But to the physician who manages these patients, the word haemophagocytic lymphohistiocytosis is quite the opposite meaning. It is basically meaning impending doom, right? Because the outcome of these patients are not that great. So it is important to diagnose them early and to treat them in a very individualistic manner. Right, so as you saw in the case, it is characterized by fever, splenomegaly, pancytopenia, liver dysfunction, and hemophagocytosis, all of that which you saw in that case. It has 2 types, the primary HLH or the familial type, where you inherit certain mutations, which we'll come to as we go on, and the acquired or the secondary type, which is either due to infections, autoimmune diseases, or malignancies. Right, so before we go on to what exactly happens, I would like to take your attention to how T lymphocytes, specifically CD8 positive cytotoxic T lymphocytes, kill other target cells. So it starts with, I don't have a pointer here, but it starts with these things called perforins or granzymes, which when the cell comes into contact with the target cell, the cytotoxic T cells, also natural killer cells, would insert these perforins into the cell, and through the perforins, it will insert granzymes, which will cause cell lysis. And these are made in the Golgi apparatus, and they are packed in the ER. And once they are packed, these granules are taken by these chaperone proteins, like what is shown in those white color ones, the RAB27, to the surface. And once it's close to the surface, they attach themselves to the surface, which using docking proteins, and then they release these perforins and granzymes. Now, what we have to remember in the pathogenesis of HLH is that this is primarily where the defect occurs. Either you inherit a mutation of any one of these steps that we described, or you acquire it because of an infection, autoimmune disease, or a malignancy. So what happens? Sorry, I'll just go back to this one. All right, thank you, I got this. So you have a T lymphocyte that is lacking in its fundamental ability to lyse other cells, which is genetically acquired or acquired as an infection or autoimmune disease. And then when you have a trigger, which is another infection, the antigen is presented to the T lymphocyte, and it is unable to carry out its cytotoxic function. So what does it do? It informs the macrophages that you need to take over the killing, and it secretes cytokines such as gamma interferon. And the macrophages then come into the fray and they try to phagocyte this. Not only do they phagocyte, they also secrete more cytokines that activates T lymphocytes. So this becomes a vicious cycle where the T lymphocytes on one hand activates macrophages, on the other hand macrophages activate the T lymphocyte, which results in 2 very important things. One is highly active macrophages that go on to cause hemophagocytosis and hyperferritinemia. On the other hand, you have a cytokine storm, And this is responsible for all the clinical features that you saw and also laboratory features that we are going to discuss as we go on. So this diagram also shows the same thing. You have a virally infected cell, cytotoxic T cells and natural killer cells. They both try to do the cell lysis the same way. And you have a defect which is acquired or inherited. And in order to get rid of this defect, the cytotoxic T cells secretes large amounts of gamma interferon, which activate macrophages, and macrophages in turn secrete cytokines such as interleukin 12 and 18, and then you have an ideal situation for HLH. Just going back, so these at different points, you can see that you can inherit the defects, and those are what we call familial HLH syndromes, and they are managed in a completely different manner to how we manage our secondary ones. Familial ones are almost exclusively seen in the pediatric population. Adults also we see rarely, but all of the adults will have some sort of a trigger. So what are these triggers? These are important to know because in our workup, it's extremely important to find if the patient has one of these, because if you have something to intervene, your outcome of HLH is going to be very good. So infections, especially viral infections, EBV, CMV, influenza, and HIV. Intracellular infections like TB, leishmaniasis, malaria. Also because they mess around with this killing mechanism. Malignancies, by far the common are the lymphomas, and among the lymphomas also you have the T lymphomas. And finally, autoimmune diseases. Rheumatoid arthritis, SLE, and in children, JIA, right? So coming to the end of the pathogenesis, I would like to end it with another movie, which I would like to show. So this is what I like to explain. Maybe medical students don't get offended by this. So this is from the Forrest Gump, where a scene of the Vietnam War, if you can recall. So the American soldiers usually go through villages and forest in groups. And then suddenly they get ambushed by the resistance. And when that happens, they try to fight them and they can't. They call in additional help via air. And in this group of Americans, you'll always see this guy with a backpack carrying a radio communicator. And if this communication breaks down, they are unable to tell where they are, when to stop, and when to take them back, which is similar to what happens in that connection between the cytotoxic T cells and the macrophages. And this ends up with something like this, where there is continuous bombardment, where there are good cells, and it is self-accelerating. It will go on to like this, and finally until death. Okay, so that's the easy way of remembering how HLH works in the body. Okay, so coming into diagnosis, you're very familiar with this HLH 2004. So HLH 2004 came from HLH 91, which was the original criteria that was described for the HLH 94 protocol. So there are two main protocols, 94 and 2004. We'll talk about it as we go on. So in the 2004 criteria, you have the characteristic 5 out of 8. And the last 3 were added to the 94. So the high ferritin, low natural killer cell activity, and increased amount of soluble CD25. So the last 3 at the bottom were added to the 94 criteria, and you have your 8 criteria. And it's desired that you have 5 out of 8 to make a diagnosis of HLH. Of course, primary HLH or familial HLH is diagnosed based on a molecular diagnosis. Now, in addition, there are lots of other supportive evidence that points to diagnosis of HLH, and like the patient we had some of these features. Now, I want to just get your attention to a couple of features of this criteria. One is hemophagocytosis. If I ask you, do you need hemophagocytosis to diagnose hemophagocytosis? Yes or no? No, you don't. Even without hemophagocytosis, you can diagnose HLH. But if your first bone marrow is negative, probably you should keep on looking for it rather than just completely put it out. Then the level of iron or ferritin which is again something that we can debate about. Now, this HLH criteria or the 2 HLH trials were designed for pediatric patients. All the patients were less than 18 years of age, and these criteria is only validated for pediatric populations, although we use it in adults. It is not validated in adults. So one reason of this ferritin is such a low level. I mean, we see so many ferritins more than 500 in our day-to-day practice. So this ferritin is quite low, and which needs to be taken with a pinch of salt, because this is originally described for children, right? Now, the other problem with this 8 out of 5 is I have never used this soluble CD25 or the low NK activity. So essentially in our day-to-day practice, we are trying to get 5 out of 6 criteria, which seems a little bit unfair. Therefore, there is a modified HLH criteria. Again, this is based on a personal anecdote of one of the authors of the HLH criteria itself, where you can take out the low NK activity and the soluble CD25, then you have only 6. And if you get 4 out of 6, provided the ferritin is above 2000, which is corrected for adult levels, you can make a diagnosis of HLH, which is probably fine keeping with clinical presentation. Again, not validated. Of course, HLH 2004 is not validated to start with. So I think this is something that we can work with. And as of recently, I've always tried to use this. Then we come to this HLH probability calculator, or the HS score. This was originally described in France, where you have more or less the same criteria as what you get in 2004. But in addition, you will notice that you have the liver and transaminitis as well. So for each of these, you get some points. But the unfortunate thing is they give you a probability. So it's available in most of your web apps, but they give a probability of HLH. They don't give a diagnosis. They say if the probability, the score out of this comes above 90, there is about 90% accuracy that there is HLH. But whereas the 2004 HLH, either you have a diagnosis or not. Whereas here you just have a probability. So certainly it is useful. It is something you should do, but not alone. You should combine it with the HLH 2004. Right. So once you get that, the next few steps in the diagnosis is, of course, just come to the last point, is you always have to consider differential diagnosis. So any high ferritin that is not HLH. So think about sepsis or other sorts of things that can have a similar picture. Genetic testing, is it necessary in adults? The answer is no. It is possible in our setup also. It's possible we can send a NGS panel to India and get it done, but certainly not in all the patients. Certainly when you have an obvious trigger, you should not do that. But selected cases, like when there's a very strong family history, or the patient presents with certain morphological features like albinism, which is associated with inherited forms of HLH, it might be useful, because again, when we come to the management is completely different if you have a familial HLH. You do an infectious screen and a thorough cancer workup. Again, cannot stress this enough when it comes to adults. In different case series, it has shown between 40 to 70% of HLH will have an underlying malignancy. So if you can't find a malignancy and if you can't find an obvious cause, you really need to do everything possible, such as, you might have a patient with a little bit of lymphadenopathy, but do a PET CT, find the most PET avid lymph node, biopsy it. If the first biopsy is negative, biopsy it again, because again, your management will change if you are dealing with a malignancy-associated HLH. All right, so I think I'm going to stop here and let Dr. Damayanthi take over again. I'll come back with a little bit more theory to deal with the management.
We'll come back to the case again. So the diagnosis of hemophagocytic lymphohistiocytosis secondary to dengue infection was made based on the HLH 2004 criteria by Histiocyte Society. So our patient had 5 out of 8 criteria. She had fever, splenomegaly, hypertriglyceridemia, hemophagocytosis in bone marrow, and hyperferritinemia. She did not have any cytopenia and NK cell activity, and the CD25 levels, as mentioned previously, was not done. And we calculated the H-score. There was no underlying immunosuppression. Temperature was more than 102. Organomegaly was there. No cytopenia. Ferritin level was more than 6,000. Triglycerides were high. Fibrinogen level was less than 250. AST was high. And there were hemophagocytosis in bone marrow. So its score came around 265 points and the probability was more than 99%. So we diagnosed this patient as having hemophagocytic lymphohistiocytosis and started on dexamethasone at that point. And then, as you can see, fever subsided, patient became well. And according to the investigations, liver enzymes were high initially, but it came down gradually. And the serum bilirubin also, it was high initially, but later on it came back to normal. So dexamethasone was started, fever settled, and she was followed up. Serum ferritin and LDH became normal gradually. So patient was discharged home. I would like to invite Dr. Manu again to discuss about the management of HLH.
Thank you. Right. So a few slides on the management. We can discuss that as we go on in detail. The most important message I want to drive when it comes to management is HLH, each HLH patient is different and the severity is different, the duration is different. So you need to cater individually how much of treatment you are going to give in terms of immunosuppression according to your own patient, right? When it comes to treatment, there are two main arms. So if there is an obvious trigger like a malignancy or an infection, treating that is paramount. Then there is what we call HLH-directed therapy, is what is shown in this box onto your right. And HLH-directed therapy is what came out of these two trials, HLH-94 and HLH-2004. What is recommended right now is to go with the HLH-94 trial. So to just briefly tell what this HLH-directed therapy is, it has two stages of treatment. So the initial therapy is 8 weeks and continuation therapy goes on for a longer time period than that. There are about 4 drugs that we use. One is dexamethasone, which is given as was seen in that previous case, 10 milligrams per square meter, tailed off and later given as pulses. VP16 is etoposide, which is a very cytotoxic chemotherapeutic agents, which is very specific for T lymphocytes. Now this we have to remember in the protocols is given at 150 milligrams per square meter dose. It is a very high dose because it's meant for children. And children tolerate chemotherapy way more better than adults. And this dose is extremely toxic if you give it to an adult. So adults, we should start at a very low dose, maybe 50 per square meter per week. They come in vials of 100, so maybe 1 vial. And if the patient is tolerating, go up. Then the third one is cyclosporine. Cyclosporine in HLH-94 is started after the initial period of 8 weeks, whereas in HLH-2004, it was started from the onset. So dexamethasone, etoposide, and cyclosporine A were all started together. But the outcomes of these two trials showed that the mortality benefit was, there was a mortality benefit, but it wasn't statistically significant. Although you say not statistically significant, the p-value was 0.06. Almost there. Still, because it was not statistically significant, they recommend still sticking to the HLH-94. So you start cyclosporine A after 8 weeks. If there are features of progressive CNS symptoms, you can give intrathecal methotrexate. So it's a pretty simple form, a combination of immunosuppressive drugs. If we put this into an algorithm, so you have a diagnosis or a high suspicion of HLH in an adult, and you identify your trigger, treat the trigger, and just wait. Do not initiate HLH-directed therapy because they get better. If they don't, or the patient is deteriorating, and the patient has primary HLH, then you initiate HLH94, which I just described. And if they get better, they need to go for an allotransplant. These are the patients who have no doubt have a familial HLH. Because familial HLH is going to recover, and unless you do a bone marrow transplant, their life is going to be not great because it will be recurrent attacks of HLH. Then, if you are dealing with a secondary HLH and you have tried treating the primary figure first, but things are progressing like you saw in this patient, and we take the infection-associated one first, you start with corticosteroids, and we tried dexamethasone. Dexa is the choice of steroid because it crosses the blood-brain barrier and it has serious effects, and plus or minus IVIGG. So for HLH secondary to dengue, they respond very well to dexamethasone. Some of them might need a bit of IVIGE. Malignancy-associated HLH I will not discuss because I think Buddhika is going to discuss it later. Autoimmune HLH, also known as macrophage activating syndrome, the choice of steroid is methylprednisolone for some unknown reason. And if it's not controlled by that, you bring it up with cyclosporin A, anakinra, which is a monoclonal antibody against interleukin-1. And then still, if there's no response, you go for etoposide. And as I mentioned, start with a lower dose and go up. This drug-related HLH is exclusively, they discuss in relation to cellular therapies like CAR T cells and bispecific antibodies, where you use the supercharged T cells as a therapeutic agents to fight cancer. So those kind of HLH scenarios, you will not start steroids, because if you give the steroids, your T cells will die, which are the ones that is the therapeutic agents. And the first line will be tocilizumab, which is the interleukin-6 inhibitor. As equally important is the supportive measures for these patients, because with this profound immunosuppression, they need to be supported very well. So their platelets need to be kept up at a reasonable level, because invariably they are going to get very bad bleeding or ICH, and that's the end of the story. They need antimicrobial prophylaxis. It's going to be a challenge with the cytopenias, but whenever you can, you need to add them. And also, if you are going to treat them for a long period of time, be very aware of secondary infections during this highly immunosuppressive period. Okay, so that's an overview of the management, and I think I'm going to stop there. I will leave you with this image, which I had taken some time ago with my poor old camera phone. Usually you see hemophagocytosis in tissues. Once we came across this macrophage or monocyte phagocyting a platelet in the peripheral blood. So that is a very rare occurrence, and as a result, it's available in the image bank as well. Right, so thank you very much. Look forward to the rest of the discussion and the other cases.
Okay, we'll come back to our case presentation. Few words about dengue-associated HLH. HLH is characterized by macrophage activation, as discussed earlier, and result in cytokine storm. Dengue-associated HLH is a rare but potentially life-threatening condition. It is increasingly recognized as an important cause of secondary HLH. It remains a diagnostic challenge because several clinical characteristics of HLH overlap with those of severe dengue. Early recognition and treatment is crucial for successful outcome. Now, when to suspect HLH in a dengue patient? If the patient is having prolonged fever beyond 7 to 10 days or recurrence of fever after a period of defervescence. Cytopenias following initial recovery of WBC and or platelets, and very high serum ferritin, more than 10,000, significantly elevated liver enzymes or altered mental state, multi-organ failure. So I'll move on to another case. So this patient is a 19-year-old female patient diagnosed and managed as dengue hemorrhagic fever in a private hospital. Her NS1 antigen was positive, lowest WBC was 1.6 and platelet count was, lowest platelet count was 26,000, and she was investigated for persistent fever after recovering from dengue illness. So it was the 8th day of the illness with rise in WBC and rise in platelet counts. Initial investigations on the day 8 of the illness, full blood count shows rise in neutropenia, rise in WBC as well as rise in platelets. Serum ferritin level was 40,000, triglycerides were 156, and CRP was normal. AST-LT were high, and LDH was 2,909. She was referred to our hospital for further investigation and management of suspected HLH. So this is the hands of these patients, which shows the convalescent rash. The hands were very red with white spots here and there. So she was having continuous high-grade fever for 8 days, and she was conscious and rational, good appetite, no vomiting. Actually, she was looking well. Liver tenderness was there, good urine output, and there was right-sided pleural effusion. So the initial investigation showed rising of platelet counts, rising of WBC, and we repeated the serum ferritin. It was 19,000. The previous day it was 40,000. AST-LT was coming down, LDH level was coming down. So this is the ultrasound scan of this patient. There was no hepatosplenomegaly, and as you can see, there were pericholecystic fluid and the fluid in the hepatorenal pouch as the patient was having leaking. Blood picture showed reactive lymphocytes with bluish cytoplasm and adequate number of platelets. It was reported as favors dengue infection. So the diagnostic criteria were applied for this patient as well. She met only 2 criteria, fever and hyperferritinemia. We have not done bone marrow for this patient. So its score was again calculated without bone marrow findings. It came to around 146 points. The probability was 16 to 25%. So this is the fever chart of this patient. Initially she had high fever, but it came back to the baseline without any treatment. So her fever settled, discharged and followed up with repeat serum ferritin and LDH levels gradually became normal. In this slide, we have a comparison between severe dengue and HLH. The temperature is usually high in secondary HLH, but in severe dengue, usually fever settles during the critical phase. Cytopenias are common in severe dengue, but usually there may be WBC and platelet rise in the recovery phase. Serum ferritin levels, AST, LDH and triglyceride all can be elevated in severe dengue as well as secondary HLH. Organomegaly also can be there in both conditions. So when we compare with severe dengue and secondary HLH, secondary to dengue, I would like to raise this question. Is there a common pathophysiology for severe dengue and secondary dengue HLH? This question highlights the need for further research to uncover the understanding and the underlying mechanism and improve our understanding. So a few words about serum ferritin and dengue fever. Ferritin is an acute phase reactant and released in response to inflammation. Ferritin levels can be elevated in infections, including viral infections. Dengue infections can be associated with elevated serum ferritin levels when compared with other viral infections. High ferritin levels in dengue may be due to replication of virus in macrophages and hepatocytes. Higher ferritin levels are associated with more severe disease, high liver enzymes, reduced platelet counts, and coagulation abnormalities. So, dengue-associated HLH is indeed a diagnostic challenge. Let me highlight a few key reasons why this is so. Due to non-specific overlapping clinical features, HLH can be missed. Diagnosis of HLH requires fulfilling of 5 out of 8 HLH criteria. NK cell activity, soluble CD25 levels not available in routine clinical practice. Neutropenia and thrombocytopenia may not be a prominent feature in dengue-associated HLH due to the clinical characteristic of dengue. As sepsis shares several clinical features with DHF, bacterial sepsis should be excluded before initiation of steroids. It's important to note that dengue-associated HLH and bacterial sepsis secondary to dengue can mimic each other closely. Secondary bacterial infections are known to occur in dengue hemorrhagic fever. The source of infection can be either hospital-acquired or from the patient's own microbiota. Microbial translocation from gut organisms is one of the possible sources. Increased vascular permeability leading to capillary leakage in DHF may predispose bacterial entry into the blood. Secondary bacterial infections can adversely affect the outcome. Cultures are needed to identify the pathogens and to initiate targeted antibiotics. So when we consider HLH, severe dengue and sepsis, the similarities in these conditions can often complicate the diagnostic and management strategies. So in conclusion, I would like to offer a few practical tips. HLH should be considered in rapidly deteriorating patients with severe dengue. Persistent fever or recurrence of fever after a period of defervescence, cytopenia following initial recovery of WBC and platelets, markedly elevated serum ferritin and liver enzymes should alert the clinician to investigate for HLH. Early intervention with appropriate therapy will significantly improve the outcome. HLH in dengue still remains a diagnostic challenge. So, thank you. And I would like to invite Dr. Buddhika Somawardana to discuss about malignancy-associated HLH.
Thank you, and I think I have 2 minutes. So I'll quickly highlight the important messages that is relevant to this audience. So malignancy-associated HLH is one of the major parts because 50% of HLH is caused by infections, immunodeficiencies like HIV and other autoimmune conditions and autoinflammatory conditions, and 50% of HLH is caused by malignancies, and particularly hematopoietic or hematological malignancies. So as you can see in this study, which has been done on around 3,000 cases, about 1/3 of cases are caused by T or NK cell lymphomas or T leukemias. 1/3 are caused by B cell lymphomas, and about 5% by Hodgkin's, another 5% by leukemias, and about 3% by solid tumors. So about 1% of patients with hematological malignancies are found to be HLH. But however, although this is the literature, what the literature says, it's not really, maybe it's underdiagnosed. We must be missing some cases because of the overlapping features of malignancies and hematopoietic malignancies, hematological malignancies in particular, with the features and signs and symptoms of HLH. So the HLH can occur during the onset or the relapse of malignancies, or during the treatment, or even after a couple of years or months. So due to the non-specific overlapping clinical features, as was highlighted earlier by the previous speaker, HLH can be missed in malignancies, particularly in hematological malignancies. So whether we can apply the same criteria in malignancy-associated HLH is actually questionable because these criteria were developed as previously described on pediatric populations. However, we usually use same HLH 2004 criteria for our patients as well. However, and the other important thing is that the survival of these patients, the prognosis of these patients are dismal, and the median survival seems to be about 1.2 months. So whether the decision to administer HLH 94 relies on the severity of the symptoms and the clinical evolution of the course of the disease. So usually we use the HLH94, but however, in malignancy-associated HLH, the underlying malignancy should be the priority of the treatment. Now, for example, if we have a T lymphoma patient, we usually use cyclophosphamide, doxorubicin, prednisolone, and vincristine for our treatment. But in T lymphoma patients, we usually include etoposide. So in HLH, the most important agent to treat is etoposide. So the combination treatment, sometimes we use a combined treatment of both HLH94 protocol as well as the lymphoma protocol. We sometimes replace prednisolone, which is in the treatment of lymphoma, with dexamethasone, which is in the HLH94 protocol. And I can remember a patient who was very young and came with the T lymphoma and found to have HLH, fulfilled all the criteria, and we used this combined protocol and he did well. However, after a couple of months, maybe like about 6 months, he relapsed, and unfortunately the disease progressed very rapidly and died before even we couldn't do a transplant, autologous transplant, before the relapse. All patients with newly diagnosed HLH, a thorough search for underlying or associated conditions must be undertaken, and that should be a take-home message for all the physicians here. And treatment of HLH in adults is mainly directed against the underlying condition, particularly in malignancy-associated HLH, but corticosteroids and IVIG and etoposide in severe cases should be not withheld to control the hyperinflammation. And this was described by Manu earlier. So just a small word, if I have time, maybe a minute. Allogenic stem cell transplantation in HLH. So this is the only curative option in primary HLH. So it is indicated in primary HLH and also considered for adult patients with refractory or recurrent HLH in the absence of treatable underlying conditions. You try to find out another underlying cause. Usually adults have the secondary HLH rather than the primary HLH. However, there are patients who have primary HLH but are adults. So I had one patient who is now doing well still after, now even without an allogenic transplant, after administering the HLH94 protocol, having primary HLH, doing well for the last 2 years without any recurrences. Unfortunately, we couldn't do any familial genetic markers because of it was unaffordable for the patient. And we have to consider in asymptomatic carriers, now, if we are doing allogenic stem cell transplantation for these patients, the donors, if we are selecting donors, we have to be mindful about the family donors or the sibling donors, because they can also be carrying the HLH-associated mutation. So biallelic HLH-associated mutation carriers should not be used as donors. So siblings and other relatives are tested for the presence of HLH mutations before being considered as donors. And allogenic transplant is avoided in individuals with active disease because of the cytokine storm, which increases the risk of graft versus host disease and other complications. Thank you.
On behalf of the Sri Lanka College of Internal Medicine, I would like to thank all three speakers for their excellent presentations and the excellent MDT discussion, actually. And because of the time constraint, we are not able to entertain any of the questions. And
I will cordially invite Dr. Shamita Disanayake to hand over the certificates to the resource persons. Thank you. Dr. Buddhika Somawardana. Dr. Manu Wimalachandra.